So, firstly, I'd like to thank the Malnutrition Task Force and particularly Leslie and Sophie for organising this learning event today. And for everyone else that's spoken, it's been really very interesting. I'm an advocacy worker and I specialise in health and social care at 25% ME Group. So, we're a national charity which supports people with severe and very severe ME. And I have a particular interest in malnutrition and tube feeding. So, ME, my myalgic encephalomyelitis, also known as chronic fatigue syndrome, is defined by NICE as a complex, chronic, fluctuating condition affecting multiple body systems. It affects approximately 250,000 people in the UK, and it has many similarities with long COVID. And it ranges from mild, where people are probably still able to work, but have had to give up on all leisure and extracurricular activities, to very severe, and an estimated 25% have severe or very severe ME/CFS, and they're housebound or bedbound, and some of the most severely affected will require tube feeding. Quality of life for people with ME/CFS is lower than in many other chronic disabling conditions, and very little demographic data has been collected on ME patients, so it's not known how many of these patients are actually older. However, as patients typically develop ME/CFS as teenagers or young adults, and there isn't a cure, many patients have been ill for decades, with some being severely affected from childhood right through to older age. And for those ME/CFS patients who are older, comorbidities associated with old age, such as heart disease, further contribute to the disease burden. So the cardinal symptom which distinguishes ME/CFS from other conditions is post-exertional malaise. And that's the worsening of symptoms associated with minimal outputs of activity. And that can be physical, cognitive, or emotional energy expenditure. And of course, it impacts nutrition and hydration. And in the more severe cases, even chewing triggers post-exertional malaise. ME/CFS can cause diet and nutritional problems across the severities, and that ranges from difficulty buying and making food to severe chronic gastrointestinal problems. And one study found that 85% of ME and 65% of long COVID participants had gastrointestinal problems. There are also comorbidities associated with ME/CFS that can further compromise nutritional intake, and they include irritable bowel syndrome, mast cell activation disorder, postural tachycardia syndrome, fibromyalgia, and also gastroparesis. And we know the first line advice for the management of POTS is to drink 2 to 2.5 litres a day and to increase the salt intake and have small, frequent meals. And when we're talking older people, there may be additional illnesses that may be directly or indirectly impact on nutrition and hydration, or medication which impacts on nutrition, so when people are able to eat. And people with poor mobility may also not be keen to increase their fluid intake because of concerns around toileting. In fact, sadly, due to a lack of care call, I can think of examples where people have actually restricted their fluid intake. Given the high incidence of gastrointestinal symptoms and food intolerances and comorbidities, difficulty shopping and cooking, and inability to maintain a healthy weight or unintended weight loss leading to malnutrition is common. So, what does NICE tell us about ME/CFS and nutrition? Within NICE Guidance 206, that's the guidance on ME, there are 11 mentions of the word diet or dietary, 4 mentions of nutrition, and 3 mentions of malnutrition, and 1 mention of tube feeding in relation to people with very severe ME/CFS. So it highlights there may be nutritional issues for people with ME/CFS. There's a section on dietary management and strategies, and nutrition also comes up within the section on assessment and care and support planning by an ME/CFS specialist team and care for people with severe or very severe ME/CFS. Within the section on dietary management and strategies, it covers symptoms and their management, including the importance of working with carers and family members to ameliorate symptoms, particularly nausea, to find ways of minimizing complications caused by gastrointestinal symptoms, such as bloating, changes to appetite, swallowing difficulties, sore throat, or difficulties with buying, preparing, and eating food. It's worth noting that for some people with more severe ME/CFS, even just getting food and preparing it can be difficult. And when you break down making a meal, there are multiple components. So from buying the food, preparing the food, and these all take a significant amount of energy to complete. They may also be dealing with digital exclusion, and their income or lack of income can impact their food choices. People with ME/CFS, particularly at the more severe end of the spectrum, are often on low incomes, and certainly those with severe and very severe ME/CFS are reliant on benefits because they're too ill to work. And they often have a high disability-related expenditure, so they may not have much available money to buy food with. And where the carer is a family member, they may have had to stop working to care for the person with ME/CFS, so the household may have lost two incomes. Under dietary management, it says to refer people with ME/CFS for a dietetic assessment by a dietitian with a specialist interest in ME/CFS if they are losing weight, at risk of malnutrition, gaining weight, or following a restrictive diet. The NICE guidance also mentions dietetic support within ME/CFS services, so within the ME/CFS clinics. It says that people with ME/CFS should have a dietary assessment when at a clinic, including weight history before and after the diagnosis of ME, use of restrictive and alternative diets, and access to shopping and cooking. Now, ME/CFS services vary widely in terms of what they provide, and many actually don't have a dietitian as part of their services. Some are able to provide dietetic support from their regular dietetic clinic. So for those patients that have mild to moderate ME/CFS and can attend clinics, dietitians can help them to optimize their diet whilst minimizing energy demands and gastrointestinal symptoms. But for people with severe and very severe ME/CFS, they're not going to be able to go into clinic because they're just too ill, and trying to do so would cause very significant post-exertional malaise. So many of these patients aren't actually being seen in secondary care. And since the COVID pandemic, we've seen some of the clinics providing remote consultations, either over the phone or a video call. However, it's very difficult to provide nutritional screening like this, and services need to be funded to provide domiciliary care for these patients. Then we move on to the section on severe ME, where nutrition is covered in more detail. It outlines the gastrointestinal problems people with severe ME may have, and these include nausea, incontinence, constipation, and bloating. As said, refer people with severe and very severe ME/CFS for a dietetic assessment by a dietitian with a specialist interest in ME, and that people with a severe or very severe ME/CFS who are at risk of malnutrition or unintentional weight loss because of restricted diet, poor appetite, for example, linked with altered taste, smell and texture, food intolerances, nausea, difficulty swallowing and chewing should be monitored. And it's really important to have a weight history for those patients and to use a validated screening tool, such as the Malnutrition Universal Screening Tool, MUST. And MUST not only looks at the weight, but also things like weight loss over the previous 3 to 6 months. And for people with severe ME/CFS, they often can't stand to be weighed or tolerate being weighed in a hoist, so it may be necessary to do a mid-upper arm circumference measurement. Sorry. NICE also says to give advice which could include eating little and often, having nourishing drinks and snacks, including food fortification, and finding ways of eating to conserve energy, such as foods with softer textures, using modified eating aids, particularly if someone has difficulty chewing or swallowing, and with oral nutritional support and enteral feeding. So we can see from the guidance that people with ME/CFS can experience problems with nutrition and hydration. Now, you may remember there was only one mention of tube feeding within the NICE guidance on ME/CFS. But crucially, within the guidance, it tells healthcare professionals to follow the recommendations on screening for malnutrition and indications for nutritional support in the NICE guidance on nutritional support for adults. So although the guidance doesn't cover oral nutritional support and enteral and parenteral nutrition, the healthcare professional is recommended to look at NICE Clinical Guideline 32, which is nutritional supports for adults, oral nutritional support, enteral feeding, and parenteral nutrition, which covers when to commence oral nutritional supplements, as well as enteral and parenteral nutrition. And of course, there's the malnutrition pathway, which is an excellent resource covering malnutrition and prescribing oral nutritional supplements in the community. Despite the prominence of nutrition within the NICE Guidance 206, it seems many clinicians are unaware that nutritional difficulties can occur in people with ME/CFS, and they are more profound and usually more chronic at the severe end of the spectrum. And people with severe and very severe ME/CFS can be unable to get adequate nutrition and hydration, and that can be down to sheer debility or gastrointestinal problems, which again can be very severe, or swallowing problems, and that can mean they need tube feeding. And for this group of patients, early intervention tube feeding has proven to be beneficial. Unfortunately, we do see delays in implementing tube feeding in some cases. And in some cases, the malnutrition has been allowed to become life-threatening before tube feeding was initiated. Now, it's common practice that if a person does need to start enteral feeding, that this is done as an inpatient in hospital. For people with very severe ME/CFS who need a very low sensory environment and have such energy fragility that the hospital environment is really far from ideal. The majority, if not all, of the people with severe ME/CFS who need tube feeding are being nursed in darkened rooms, typically at home with around-the-clock care, often being provided by family members or a small group of carers who know their needs well. So the thought of going into hospital for this group of patients is very worrying. So how can we make the prospect of going into hospital less concerning? There are several documents and resources out there, along with some information within NICE Guidance 206, as to how to use reasonable adjustments to make the hospital admission and stay easier. The necessary reasonable adjustments would include, as NICE recommends, putting people with severe ME/CFS in a side room where possible, having the windows blacked out, nursing them on the quietest part of the ward, and allowing them to continue to be cared for by the people who knows them best, because that minimises energy expenditure. When staff go into the room, talk quietly, you may need to whisper and move slowly, and brief staff about what to expect when they have a person with severe ME/CFS on the ward, and allow them to be educated by the people who normally provide the care to the person. They and the patient understand their condition better than most healthcare professionals. There is one piece of guidance within NICE Guidance 206 in the section on severe and very severe ME/CFS that's applicable to anyone, anywhere working with someone with severe ME/CFS, and it's a really important piece. It applies if you're working in the community, primary care and secondary care, and that's risk assess each intervention with a person with severe or very severe ME/CFS in advance to ensure its benefits will outweigh the risks, for example, worsening the symptoms of the person. For people with very severe ME/CFS, think about discussing that with the person's family or carers on their behalf. So it's important to think, how can I minimize the exertion on that person whilst keeping the focus on them? And if we translate that into the hospital setting, we're thinking about things like the number of observations that are done in a day. Can they be done at a time when it's less impactful on the patient? Where possible, utilize what the carer knows. Use them to gather information where applicable, and of course, only with the person's consent. And I think we're probably most used to doing this in elderly medicine. We have a number of resources on our website to help health and social care professionals working with people with severe and very severe ME/CFS. And following many calls to our advocacy service on hospital admission, 4 of the ME charities put together a booklet with advice for clinicians, as well as a place where the patient can have useful information about them all in one place. And following the inquest of Maeve Boothby O'Neill, the medical director of the Royal Devon University NHS Foundation Trust, was asked by the coroner to write some clinical guidance, and they've produced a really useful template. It's authored by the clinical matron for patient safety, and the template looks at planning for an elective admission and advises staff what to do if it's an emergency admission via A&E. So for an elective admission, and that's what siting an NG tube should be, it recommends extensive planning to be undertaken by the community matron, who would liaise with the ward and senior hospital staff to arrange a bed and to brief staff. And it recommends patients with severe ME are admitted directly to the ward. It suggests an individualised care plan be drawn up by the admitting clinician, and that multidisciplinary team would input from the patient and or carer or the nominated advocate. This would outline the best bed location, travel to hospital, etc., and a hospital passport would provide information about the patient. It also looks at how staff can support the unpaid carers in the situation, particularly when they're providing care whilst the person is in hospital outside of normal visiting hours. And the template recommends parking clearance, accommodation, and providing them with meals on the ward.
I need to hurry you along, Helen.
We then come to discharge planning. Now, because of the unsuitability of the hospital environment, you want to look at early discharge as soon as it's medically safe to do so. So you should be starting discharge planning really when the person's admitted. You don't want them in hospital just because you're waiting for a feed pump to arrive. Look at who's going to be administering enteral feeding at home and make sure they're given some of the relevant training on the ward so they go home confident to do it. And that applies to stoma care as well. A small minority of people with very severe ME/CFS will require parenteral nutrition. So it's also necessary to think about the longer term provision of enteral feeding. These patients find it very difficult to travel into hospital, even by ambulance, and doing so causes significant post-exertional malaise. So based on that, explore options of the various tubes. An NG tube is usually recited in hospital fairly frequently, and its position in the stomach is identified by a pH test. And vomiting can cause the tube to move, so it's making it potentially unsafe to eat. We know some severe and very severe ME/CFS patients vomit, so what are you going to do if the pH test isn't within acceptable parameters? They may need to go to A&E to have the tube recited. Would a PEG tube be better? What about an NJ tube? They're recited electively via an endoscopy. And when you do discharge the patient, ensure that you have contact details for emergencies and out of hours. And the organisation I would recommend you provide the patient details of is Pint. They're a brilliant charity for people having tube feeding, run by people with lived experience, and they've got some really excellent resources. And do refer to the home enteral nutrition service as well, because patients find a real benefit from being supported at home with their enteral feeding. And my final slide, here's some useful resources. Thank you.
Thank you, Helen. Sorry to hurry you along, but people have found it very interesting.
Thank you.
Thank you so much, and we'll have it on the website soon.
Thank
Thank you
you.
very much.